Okay. Yeah. Okay. So we missed out those first few minutes, but anyway, so in any case, this is our scenario, all right? And based on our scenario, we're going to see our ECG, we're going to see what's going on, and then we're going to start placing the tiles in place, all right? So we have here a 56-year-old male patient, all right? He's brought into the A&E, collapsed. There's no pulse, no respiratory effort. Your team puts him on the bed and attaches the monitors. All we know is that he had a sharp chest pain, waiting for his hypertensive and diabetic medication in MOPD. He had been on a wheelchair for about 3 hours because he is also complaining of leg pain. That's all that they know. They don't know anything else about him. He doesn't come with anybody. There's nobody else to give us any collateral. That's all that we have, all right? So your mind must already be telling, okay, what could be going on? There's no initial blood pressure. There's no initial heart rate. He does have SATs, but they're 62% on room A. His blood glucose is 2.0. And as soon as they put on the ECG, this is what we are seeing. Okay. So after this slide is when we're going to start playing the game, all right? Where we start mixing and matching the tiles. So first of all, what is this? What are we looking at? So we know it's pulseless. Okay. And what do we have on the ECG? Anybody? Well, it is a tachycardia, that's for sure. It's not necessarily a VTach because it's quite narrow, right? But it is a narrow tachycardia. But the problem remains it's a pulseless tachycardia. He's got no pulse. So anybody want to venture guess what that's called? When you've got no pulse, but you've got electrical activity showing on the ECG. Anybody? Let's see, we've got somebody in the chat. Yes, Trisha, that's 100% right. We've got a PEA, pulseless electrical activity. Is PEA a shockable or a non-shockable rhythm? Non-shockable, very good. Okay, so you can talk fast and they can type. All right, so now let's go to our slide sorter. All right, so we've gotten up to there. So the question is, what are you going to do next? So there's a whole lot of slides, but the best way to start off is think to yourself, all right, what are you going to do? What's the first thing that you will do? You know this patient has got pulseless electrical activity, which means the heart is off, all right? And you know that we need to get him back to normal as quickly as possible. So what will anybody do? And anybody is welcome to join by voice or chat. It's fine. I can't just keep on hassling Wadia and Muhammad over here. So let's see. Right. Very good. CPR. Yes, that's definitely one of the places that you can start. So let's look for CPR. There we go. We've already got CPR in its place. Okay. So we've got let's just enlarge the slide. So we've got CPR. It's already in place. So we're going to start doing compressions and we're going to start doing a bag mask airway. All right. Okay. That's very good. Okay. We've started that. What's the next thing that we're going to do? And how, all right. The question is, what's the ratio? In other words, how many compressions to how many breaths? 30 to 2, very good. And every 2 minutes, what do we check for? We check for a pulse again. All right, very good. Okay, so what do you think will be the next step from this? What do we know about him so far? Pulseless. We know he's got a PA. We know he can't be shocked. So yes, very good. His blood sugar, what was his blood sugar? 2, which is extremely low. So what would you like to do? Right, so you're going to put up a line. Very good. You're going to put up a line. Okay, and you're going to take baseline bloods. Agreed. Right, let's put that up. So what are your baseline bloods? Just normally, what would you take? FPC, UNE, ESR, yeah, CRP. No, not necessarily. Would you take an ABG? ABG, the patient complained of? Chest pain. Would you consider any other bloods with it? Cardiac markers, very good. Anything else that can cause chest pain? Pulmonary embolism, and for that you take? Starts with the D, ends with dimers. Very good, D dimers. Okay, that's very good. Yeah, that's good. Parak, that's very good. Cardiac markers and D dimers as well. All right, so these are the things that we would consider to take. All right, so now you've got your lineup. All right. So once you've got your lineup, what's the first thing that you're going to give to this patient, considering he's got an HGT of 2. We've already bagging him. We're already giving him CPR and things like that. What would you like to give him now? Sorry? Not ringers? Sorry? No. You must remember, all of this is happening at the same time. So we're doing CPR, we're bagging him, we took bloods, we took that. The only thing we know is that his blood glucose is low for now. So what would you like to give him as the first thing? Very good. You'd like to give him glucose as well. All right. So let's give glucose. Okay. So we did a good thing for him. We gave him immediately 40 mils or 50% glucose. All right. Now the level is up to 10. Okay. So what's the next thing we're going to do? Because currently our patient has been with us for how many minutes now? Okay, he's been with us now for 15 minutes and we've only got to the point of giving him glucose. All right. Okay, and we've been giving him CPR. Okay. So let's assume 2 minutes of CPR has bypassed in that time. Yeah, very good. Okay. What I'm going to do is let me leave the chat up here so that we can just see the chat as it starts off. All right. Because it's just blocking off something that we already know. All right. So we've given him glucose. We've been giving him CPR now for 2 minutes. What else would you have liked to have given him as soon as this went in? Because he's got no heartbeat whatsoever. Anything else that you would like to do or that you could do after 2 minutes? Very good. Adrenaline. All right. So we've got Barak over there giving us a good few ideas. So let's find adrenaline in here. Do we have adrenaline? I think we do. Ah, there we go. There is adrenaline. Let's pull it out. Okay, so you want to give it after the glucose. All right. So adrenaline, normally given every 4 minutes. All right. But we've given the first one. Okay. Right. So finally, after 15 minutes, now we gave him his first adrenaline. Okay. So I don't know how you think our patient is doing, but I think we've got to pick up the pace a little bit. All right. Okay. So now we've given him adrenaline. What's the next thing you're going to do? Very good. Let's continue CPR. For how long? Very good. And after 2 minutes, what do we do? Check. Hey? We recheck and what? Do we give him adrenaline? Do we not give him adrenaline? No adrenaline. Very good. Why? Yes, that's good. Adrenaline every 4 minutes. So what would you like to give him again now? No, not amiodarone. All right. Amiodarone doesn't really come into the, it's a good guess, but it's not for shockable rhythm, non-shockable rhythms. All right. You use it for it's for shockable rhythms, not non-shockable rhythms. Remember, we're not shocking him now. All right. So we've given him CPR, given him 1 adrenaline, and after 2 minutes, we've done a pulse check. We haven't gotten anything. So very good. We should continue CPR. All right. So we continue CPR. Okay. And after we continue CPR, is there anything else that we should do after another 2 minutes? Very good. Recheck the pulse. All right. Oh, sorry. No, this is the wrong one. My apologies. I also pulled out the wrong one. That's the amiodarone one. Right. There we go. So we then give him adrenaline. So adrenaline goes in every 4 minutes. All right. So basically every second pulse check, that's when we give it. All right. Okay. So we've come that far. We've actually done quite well. Okay. And if we're still not succeeding, then we'll continue with that. But a very strange thing has happened is that after he is, oops, sorry, still learning the whole slide sort of thing. Just want to make sure it gets into the right place. Let's just see, we were here. Okay? So after we have done all of that, all of a sudden somebody alerts us to our ECG, and this is what we are seeing. Any idea what this is? This is not your heart rate, by the way. Yeah, it's VFib. Very good. Okay, so that's VFib. So is that shockable or non-shockable? Very good, it's shockable. So what's the first thing that you're going to do? So in other words, we defibrillate the patient. That's the very first thing that we do. Okay, so we apply our stickers, put our gel, switch off our oxygen. How many joules are we going to give the patient? Very good, excellent. Wow, you guys are actually doing really well now. Now we're getting into a kind of routine. So now we've gotten the patient to that after another 2 minutes, all right? So adrenaline go, where are we now? Right, so we're down here, all right? So how many joules? Okay, now at this point, all right, while we've just given him the shock, we're going to still continue doing our CPR. We have to start considering our causes. We can't just keep on doing CPR, all right? So let's spend a few minutes on this and try and figure out. So we know that he fell down, he had a sharp chest pain. We know that he was having leg pain as well. And we know that he was hypoglycemic, which we corrected, all right? Because we have to start treating reversible causes as well. So let's go through the causes, all right, of cardiac arrest. And let's start thinking what could be our most important before we carry on. So do you think he's hypovolemic? They had no area of loss, right? Hypoxia? Unlikely, because you didn't come in for a hypoxic problem, you know. Acidosis? Possible. Elderly man, could be renal, something like that, but it's not looking likely, you know, because he didn't look acidotic, he just collapsed, all right? Hyperkalemia, hypokalemia are always a possibility. We can never say no. Hypothermia? Not really. I mean, he was stable. He was just sitting around. Hypoglycemia, definitely possible. But when we gave him glucose, he didn't improve. You would expect him to improve. Toxins and tablets can never be completely out of the question, but it's unlikely in this stage, all right? Cardiac tamponade, without trauma, it's unlikely. Let's put it that way. Tension pneumothorax? Yeah, I don't really come in presenting with that, but we don't know. It could be a COPD. What's an easy way to check? Listen to both sides. Auscultate, you may not have air entry on one side, and you feel for the trachea. And if the trachea is deviated, then you know on the opposite side, then you do a needle decompression. Thrombosis or myocardial infarction, possible? Very possible in this patient. Thromboembolism, pulmonary? Very likely as well. Trauma, not really in this case. Okay. All right. So now we've kind of looked through all of that. Okay. So we've tried. So we're coming up to a bit of a thing. So what's happening now is that, again, we've given him this. All right. What are we going to do after we give him his joules? We're going to continue with? Very good. We're going to continue with, we're going to continue with CPR. So let's just move that up here. Just want to move it behind. Let me just move these guys across. 1 second. All right. So we're going to continue with that. Right. Sorry. All right. So we're going to continue with that. And what do we do after that? Hey? Yeah, we can recheck what we've got. Let's say that we've got no pulse. But anyway, let's say, all right, we recheck. All right. Adrenaline goes back in. Okay, and we still, All right, so we're still going to give him adrenaline and we're still going to check for that. And what else are we going to do at the same time? Get ready to? Hey, not a bad idea, but before that, don't you think we should shock him again? Okay, he's still in a shockable rhythm. Why shouldn't we shock him? There's no harm in shocking him again, that's for sure. All right, because we know he's got a shockable rhythm. Now, is there any other information you would like at this point?
Between the first shock and second shock, see, we did the first shock.
And we did CPR for 2 minutes.
And then we rechecked.
He's still got a shockable rhythm, yeah. And shock again, and we can give him, what you call it, adrenaline. Yeah, all right, which is just hiding on this side, all right. So these two can be swapped. You can give the adrenaline first, or you can do that first, all right. But that's not the question I'm asking. Is there any information that you would like specifically? Because we took all those bloods at the start. Do you think we should have asked for the bloods a long time ago? All right, we assume that we have a functioning lab in this case, all right? Okay, so our lab does send us the results, all right? Now, by this time, you must remember, we've only been in it for about 10 minutes. Well, I mean, our patient's dead. He is long gone, all right? Because we're hitting about 25 minutes, nearly 30 minutes, all right? But let's just pretend we got a functional lab. And let's say this is what comes, all right? So I just pulled out some important values. So his pH 7,067, so he's acidotic, all right? And his PCO2 is 10, so it's a respiratory acidosis, all right? Potassium is normal, sodium is normal, glucose is normal, lactate is high because of hypoxia. His base excess is quite low, minus 13, and his corrected bicarb is 17. So we know he's got quite a bad respiratory acidosis, all right? His HB is 12, his urea is 12, creatinine is 69. His TROP T is only 55 and his CK is only 89, but his D dimer is 4.7. So what's the most likely diagnosis? Yeah, very good. Pulmonary embolism. All right. So would it have been nice? We should have asked for this a long time ago, isn't it? All right. So let's go back now. Now, in an ideal world where we would have asked for this, we would have actually asked for bloods closer to, let's see, that's 2, 4. We would have started demanding our bloods around here. All right. Yeah. Once we start, or let's say even, let's put it just in, let's just put it here after the shock, all right? Because we would have wanted to know by that stage what's going on, what's happening, and how we're going to treat him. Okay, so anyway, that's the thing. Now, another one I want to get to just before we carry on. Now, this is intubation. Nobody spoke about intubation, but where do you think we should have intubated him? Yeah, very good. We shouldn't have intubated him towards the end, all right? So we could have intubated him around here, let's say. Agreed? Because we could see this wasn't going well. So even before we had the VFib, we could have intubated him, all right, which would have started to help us. Okay, all right, it's not a problem. Even if you intubate eventually, it's better late than never, all right? So let's go back to this. So if we are still worried about whether we have a pulmonary embolism or not, we can do an ultrasound. So I'm just take this out. Sorry, let's put this one here. Okay, so let's put that one there. And then we're almost at the end, don't worry. Okay, so just to show you, so this is how we can look at it on an ultrasound, all right? So what do you expect with a pulmonary embolism? We expect that the heart is trying to push against this huge blockage in the lungs. And which ventricle? It's the right ventricle that's trying to push. Okay, so what we expect to see is a very dilated right ventricle. Now, this is called the parasternal short axis. So that means we place the probe next to the sternum, and then we have a look in the short axis. So we're cutting the heart in the short plane. And you can see the right ventricle is much larger than the left. And even in this one too, which is the parasternal long axis, where the apex is around there. That's the left atrium, left ventricle, and the aorta. We can see how huge this right ventricle is, all right? It's massive. So that was another thing that could have given us a clue as to what's going on, all right? But anyway, we're almost at the end. Don't worry. Okay. So let's see, did we get it right up till there? Yes, we did. Okay. So we reshocked him again. And then, yes, we would give him then the next part of it, it already falls into place, all right? So we would give him amiodarone, all right? Because we want to try and stimulate that heart to come out of its fibrillation, okay? So amiodarone definitely generally goes in about every 8 minutes. It can overlap with adrenaline, all right? So don't worry about it. So we generally give about 150 milligrams at a time. And once you clear this, once you've given the adrenaline, then all that you are doing is that you are going back to this part here, right? So you're going to give the joules. Okay, you're going to skip the H's and T's, that and that, but then you're going to continue CPR for 2 minutes. Then you're going to give him adrenaline and you're going to give him another shock. We're supposed to have one more. Wait, let me just put that in there. Let's just duplicate slide. So sorry, that's the only one that's missing. All right. So we're just supposed to have one more CPR in between there, and then we have amiodarone. And if there's still nothing, then we go back to the start here, all right? Then we start to see, okay, as to what might be going on. Now, how would you treat this pulmonary embolism? There's a few ways. What we can do in an outpatient setting, Clexane, all right, or any of the novel anticoagulants, or even heparin if we really have to. But heparin is kind of like, yeah, it's C4 explosive. You know, it just knocks out everything, and it's very difficult to control. You know, especially unfractionated. And then we would give something like streptokinase and things like that. All right. So let's have a look now at our presentation. All right, because now we've got to present it to somebody else. All right, one day you guys will have to present it. So let's start. Let's get back to the front and let's see if it makes sense to us. All right. So we talked about having a Resuscitation Megacode. We talked about how it will work and how we are going to do it and our scenario. All right. And then we found the pulseless electrical activity. We started doing CPR and bagging. We started taking bloods and putting up a line. We gave glucose for the low glucose. We gave adrenaline for the PEA. We continued CPR and we continued what you might call it, compressions. And then because it was only 2 minutes later, we didn't give another adrenaline. We continued for another 2 minutes and we decided to intubate the patient. Okay. And then we continued. We gave compressions and we gave bag mask. And then after another 2 minutes had gone by, then we gave adrenaline again. And that was when our ECG changed to a ventricular fibrillation. Once it changed to a ventricular fibrillation, we did the first thing, which was shock. We didn't answer how many joules, but it should be around 200. Okay, and you can go up from 200 as well. And it depends on the machine as well. Okay, then we had a look. While we were busy with all of this, we were looking and we came down to the possibilities of an MI, pulmonary MI. We said toxins, tamponade, hypoglycemia, hypoxia, acidosis. We had to look at all of them, but these were the two most likely ones. All right. So we got our bloods back from our functional NHLS that day, and they gave us an idea that it was most likely a pulmonary embolism, which does make sense. You had a man who had leg pain for a few days to the point where he couldn't walk, who had to sit still for 3 hours in the MOPD. He's diabetic, he's hypertensive, and sudden onset chest pain. So that means the thrombus shot off and embolized to his heart. Okay, could have had a CVA at the same time. It just happened for him, it went into the lung. Okay, and we could have also quickly confirmed with ultrasound just to see, okay, is this really what we're dealing with? Okay, and we said that's what it would look like. Continued with our CPR, we continued with our bagging. We gave him the first adrenaline, we shocked him again. We continued the compressions. We gave him amiodarone and we continued that. And we gave him Clexane and things like that. Now, we took a bit long because we were discussing. But if you did these steps in the way that they were supposed to be done, do you think our patient would survive? Yeah, our patient have a very good chance of surviving. It depends on the patient's own reserves. But if you had to, for example, be taken to court by the family, you have everything to defend yourself. If you have to get called to an M&M meeting, nobody can turn around and say, oh no, you didn't do due diligence or you didn't do what was necessary to save the patient. You actually did everything that was in your power, which is all that you can do as a doctor. All right. I always tell you guys, there's two types of doctors. There's a doctor who stands in front of the patient's grave and say, hold on, don't go in there. And then there's a type of doctor who says, come, let me make you comfortable inside your grave, all right? And helps them to go in. So don't be the second type, all right? So I'm not sure if there's any questions or anything that you guys would like to know. Generally, mega codes are very nice to do on the dummy and you do it in real time and things like that. It's not possible because we're all so far away from one another, but hopefully everybody can just have a look. So we've covered quite a bit of resus actually over this year. Now we've had a resus month. So next week we'll just do an ECG, we'll start our progress again, and then we'll take it from there. And yeah, that's just a joke to finish off. And if you guys do have any questions or any concerns, but the thing is, the way that you have to learn this is so that you can immediately pick these things up. All right. You must know immediately what is my next step, what is my next step, what is my next step. The most important is don't panic. For example, how? The best way to function fast is not to panic. And to remember, you're only dealing with two algorithms, one for non-shockover, one for shockover. That's it. You break it down into those two simple parts and you do the best that you can. And number two, there should always be these algorithms on the wall next to your resus bed, because it happens to all of us. You start panicking. There's outside factors. You know this person, or you know somebody who knows this person, you know, and that starts coming into it. The old gogo is standing over there and screaming at you, you know, because it's her last son that's left, you know, things like that can, and you can get flustered. So make sure you have it on the wall so that at least you can still refer to it in case you mix it up. But unfortunately, it just has to be put into your mind. That's it. All right. And it's something you have to refresh from time to time. So I hope you guys enjoyed it. I'll post it up on the group later. If there are questions or anything that comes, I mean, it seems simple. And the truth is that it is simple. It's just not to get confused and not to panic and just to know when to do things. Okay. All right. No problem. No problem. All right. So I'll see all of you next week then. Thanks. Right. Bye.